Eichstedt, who is a critical care nurse and family nurse practitioner.
Yep.
And on her way is Jennifer Katsuyama, who is a physician assistant. So hopefully, today's lecture will be about scope of practice in healthcare, so it'll be very interesting for all of us, so thank you.
Are we live?
Yes.
Awesome. All right, so you guys got me again this week to be moderator, and we're waiting for the PA to come a bit. In the meantime, I might as well get started. So we have nurse practitioning. I've talked a little bit about that in the last few lectures. I'm just curious, how many of you guys remember what nurse practitioning is? Do you guys remember when we talked about that? Oh, perfect timing. Jennifer, come on in. We just started. We just started. Okay, this couldn't have been any better.
Hi.
All right,
I'm late.
Jennifer. Jennifer is the physician assistant. So, perfect. So, I basically talked a bit about how these roles are constantly expanding in the past and even into the future, and how it could potentially impact roles of physicians and also provider care just across the board. Also, players like Walmart coming in, and how the whole workforce will take a whole dynamic shift on top of that. So, I am going to just go down the row and ask them in 2 minutes, if you can, tell us, if you can, from when you were an undergrad, kind of the pivots and journeys you took to get to where you are today. So, Julie?
All right, so I am trained as a nurse practitioner. I was a neonatal nurse practitioner. So I feel like I had a whole career before I'm in the career that I was in, and obviously I'm old. And my daughter's leaving for college tonight, so that gives you an idea. And so I got an RN degree, went back to school, got a master's degree. Back then you got something called a clinical nurse specialist. Ended up going back another year to get my nurse practitioner education so I could sit for the exams. Worked in that field for quite some time and ended up through that work working with some doctors who had developed a software program, and this was back in the first.com era. And so they were taking it to market. They formed a company, and they asked me to come work with them to actually represent and sell their product. And so I stepped out I actually continued to moonlight as a clinical, because as a practitioner, any of these roles, you can work 24-hour shifts or 12-hour shifts or whatever. And so I would do that on a weekend every month, and then worked in this software company and traveled all over the United States, repping this product. But while I did that, I had to learn a lot about hospital information technology, which really was my street smart education in technology, blending it with my clinical background. And through circuitous route, and I won't bore you with it all, ended up back at Kaiser Permanente. I had been there as a nurse practitioner, left and went and worked for this company. Came back to them, did some more program development for them, and left again and worked for a consulting firm, which was a boutique healthcare consulting firm that wanted to hire me because of my tech background. I'm like, I have no tech background. I'm a clinician. And they're like, well, no, we really need operational folks, because what you'll learn in this field is that the tech is kind of easy. The tech is there. It's how do you put tech into practice that is the challenge. And so I joined them and did consulting with them, and then IBM bought our firm, and it was like, ugh, hated working for IBM. And so I went to Kaiser, and I ended up getting placed at Kaiser as a consultant. So I was like, you guys should just hire me. I live in Oakland. So they did, and I've been in this role for about 10 years now in information technology. There's a few of us as clinicians on the leadership team, and I'm in the care delivery part of our IT organization, and we are responsible for all the applications and technology that are used to care for the members of Kaiser Permanente. So I'll stop there.
Excellent. Thank you, Julie. Sarah?
I have a different story. So I went to undergrad at Johns Hopkins, and I didn't really know what I was going to do. You don't need to pick a major there till the end of your sophomore year, so I was just there taking classes. And I did a lot of volunteering, and one day, who knows why, into my mind popped nursing. Nursing, I want to be a nurse. I knew nobody who was a nurse, really. I didn't know what a nurse did. But I was so sure I was going to be a nurse. So I applied to nursing school at Hopkins, and then got in, and did some traveling in between that sort of solidified help people of the world. And so I went through nursing school. It's hard work, but it's also rewarding. And then I moved out here to San Francisco, got my first job in the ICU, and I loved it. I worked there for 3 years, and then it sort of felt routine. Even though every patient's a different experience, I thought, let's go back, learn more. What can I do next? And because of some personal history and challenges I had had with primary care, I thought I could do primary care. I could do it better. And also, it gives me a lot of options to go into other different fields. So if I went into family practice, I could work with kids. I could work with geriatrics. I could work inpatient, outpatient. Lots of different options. So while I worked full-time as a nurse, I went back to school part-time, got my family nurse practitioner degree. When I graduated, I quit all my jobs. I went traveling for a while and came back, and I worked in occupational health as a nurse practitioner and a clinic manager for a little while. And I recently left that job because it wasn't really the direction I wanted to go. And here I am deciding what I'm going to do next. And I do work back at the hospital part-time as a bedside nurse, the same job I did when I graduated, but I'm sort of in a transition period right now.
Awesome. Thank you. Jennifer?
My name's Jennifer Katsuyama. I'm a physician assistant. I've been a PA for about 6 years now. I just recertified. My path, how did I become a PA? Well, I was a collegiate athlete at University of San Francisco over on the other side of the bay, and I had a few knee surgeries during my career, and I remember talking to the surgeon, and I remember always seeing this other person who was taking care of me, and I'm like, man, you kind of do a lot. You see me every time, you tell me what I need to do, you assess my knee, you drain it, you give me an injection, send me on my way. The only time I ever saw a surgeon was before surgery. So that's kind of fun. What do? You have a lot of patient interactions. Great. He's like, oh, I'm a PA. What the heck? I've never heard of a PA. What's PA stand for? He said, physician assistant. I was like, oh, I'm going to go look that up. And this was going into my senior year of college, mind you. Okay, so you don't have to figure out what you want to do right away. I thought I wanted to do science, maybe research. I'm going to go study some sea turtles for a while. And once I tried that, I was like, oh, sea turtles, it's kind of fun to watch them, but they don't really talk back. You don't get to interact with them. So I thought for sure I want to do something interactive. It was teacher or healthcare. So that's how I landed into PA school. I looked it up and said, this is great. I'm going to try to cram all my prerequisites. And I did. My senior year in college, I busted my butt. And I got into PA school. Granted, it was in Virginia, but I did it. And then I came back to the Bay, applied for jobs, and the market was wonderful. Plenty of opportunity, and I've been in orthopedic surgery ever since.
Where do you work?
Kaiser Permanente.
Oh, you do?
At
Which one?
San Leandro.
Oh, excellent.
Yeah, so I first worked for a hand surgeon first couple years, and then I just recently moved to Kaiser Permanente. If you guys don't know, there's several medical centers around the Bay Area. The closest one here is Oakland, and then San Leandro is a brand new medical center that has opened up. And at first Kaiser Permanente, when I was growing up, you didn't want to work for Kaiser Permanente. It didn't have a great reputation, but right now with healthcare changing, PAs, nurse practitioners, and different mid-level providers are really vital to moving healthcare forward, but also the job market is great. And I would have to say my professional satisfaction is excellent.
Awesome. Very good. So I think, let her raise a hand because I forgot. How many guys are pre-med? 1, 2, maybe 3, 4. Okay, so roughly 4 out of this. All right. How is the roles of and for what in 1 minute? What is the training that for an NP and a PA like? From the time you get out, how many years of school, what the test you gotta take? Is there anything like residency? What's it cost roughly in tuition? So Julie.
Well, I'm like probably the bad person to ask because it was a long time ago. But nursing is definitely a 4-year bachelor's degree, and I believe in California now you cannot sit for the RN exam without a bachelor's degree. The nurse practitioner piece is a master's degree, and now it's 2 years. It took me 3 years because they weren't combined programs back then. And obviously the cost is gonna depend on where you go to school. I went to USF. USF is expensive school, so that was pricey, but my master's degree was at UCSF, which was much more affordable. And I did have to do a residency, and because I was focused on neonatal, I did mine at Denver Children's, and I wanted to do transport, and so I worked with the transport team at Denver Children's Hospital, but my residency it was probably 2 months. I stayed over there for 2 months and worked with that team and flew all over Colorado. And I set that up because I had connections there and friends there, so I could make it happen. But we pretty much could pick where we wanted to go and set that up. So I'd be curious to hear how it is today.
I think it differs depending on what school you go to and what state to a certain degree. But so nursing is interesting because there's a lot of paths to it. It's almost too many, and it's so confusing for the consumer of healthcare, really. So there's still the licensed vocational nurse, actually, which is an associate degree, I believe.
Yeah.
I actually work with some nurses who graduated within the past 10 years, associate degree, and they are RNs as well. So interesting, that's still there. The majority of nurses you'll find are bachelor's educated, so you do 4 years, like Julie said, and then if you want a master's degree, you go back for 2 years usually. However, there's this thing called direct entry, which most people in my class did that. It has a slightly different name depending on what school, but you can go with any bachelor's degree, not even in nursing or healthcare, and do 4 years total and get your nurse practitioner. The first 2 years are the RN curriculum, and then you sit for the RN boards, and then the last 2 years are the NP. So there are a lot of NPs out there who haven't worked as an RN before. So that's actually a popular route to go these days after people realize what they thought they wanted to do was not exactly what they wanted to do.
Yeah, so you get English majors and history majors. Yeah.
But at least the salary for nurses and the schedule for nurses, 3 days a week is full time. A lot of places you go, it makes it really easy to go back and get your master's and to pay for it as you go. So Samuel Merritt's one of the more expensive schools. It's about $50,000 for your 2 years master's. I'll tell you, I paid that off in 2.5 years. Basically,
working overtime.
I actually worked less than full time, and you can pay it off because nurses get paid well.
The schooling for PA is usually a 27-month program, which is a little over 2 years. It's designed in a medical model. You need a bachelor's degree for entry, and right now they're pretty much going all towards master's programs. So I think a little while ago they were associates, a handful of bachelors, but by the time any of you consider school, it will be master's. So to enter, you'll need a handful of science prerequisites, your basic biology, anatomy, physiology, and then some genetics, but basically the pre-med route in addition to a bachelor's degree. Like I said, it's 27 months, so the first year it's basically mini medical school, very concentrated book work to build your foundation of knowledge, and then the last year plus is out in the field in a residency type setting doing clinical rotations, and what that entails is you putting your knowledge to work, practicing alongside with a supervising physician, training you to be on your own. So you got to be up and ready. You're not going to know anything going out there, but that's the time you utilize to build up as much as you can. Because in 2.5 years, you're out. Once you pass your boards, you're licensed to practice. Can you believe that? 2 years. You're allowed to take care of somebody, and that seems like not that much, but as for a PA route versus, and I don't know if you're going to go over this too, is MD route, the scope of mid-level practice can cross over a lot with physicians.
A tremendous amount. And what's interesting, and I think what you're getting at in your questioning, is that really the level of responsibility for your practice. I mean, my neonatal nurse practitioner role at Kaiser Permanente, I was explaining earlier that I got hired, I was the first inpatient nurse practitioner they hired, so we sort of brainstormed the program together. And my boss was the was the chief of pediatrics, so I was hired into the medical side of Kaiser Permanente, but everybody identified with me as a nurse, so it's just an interesting role. But I quickly had to have a lot of responsibility, so I had a caseload of patients. I worked with the neonatologist. I was just another part of their team. I had a caseload. I would have to go in the morning and get all the, what happened overnight with my patients, get it all tuned up, then we'd go on rounds, and there was a residency program also at Kaiser Oakland. So I would round with the neonatologists and the residents, and once you master that role, then it was really fun teaching the residents, because I have a very different education as a nurse than a physician does. And so it was a nice blend, and I was also explaining that today, the pediatricians that see my kids are residents that were in that program with me, and their careers as pediatricians at Kaiser Permanente. But it's a shorter path to getting to that practice than the whole medical school route, and also when you look at the cost of school, So I think, for you to be out and doing what you're doing as a PA, in 2.5 years is pretty impressive.
Yeah, cost-wise, the PA school I went to is private school, and that probably was close to 40,000 a year, maybe a little less. But the salary range, depending on where you work and what state, could be, I think the median is 80 to 90,000, and then obviously in more urban areas, higher. So where we live, California, I think pays the best. Kaiser pays well. I think out of everybody, just because healthcare is changing, so salaries are changing as well. But I think my position is generously compensated for the amount of time I've had invested and the return that I've gotten for a lifelong career.
I'll say nurse practitioners don't, there are few programs I think where there are residency, but I think mostly you're just kind of out there and you go for it. So that's one interesting difference. After year, 2 years, you're out there, you're practicing, and you can negotiate individually with your employer how much extra supervision or not, or what your role might be. And also in nursing school, it's slightly different than the PA or medical model. We would do our curriculum, and then for that, say pediatrics, we learn about pediatrics, then we do our clinical rotation in pediatrics at the same time, and then we move on to the next subjects. It's kind of, I think from the first semester of nursing school, we were out there in the hospitals doing our clinical work, as opposed to stacking one than the other. Not to say one is better than the other, that's just kind of a difference too.
So, because I remember my history as a physician and how I had to work, basically, and some of you guys who are in pre-med route, you'll learn this, that in a physician role, you're actually going to be in a very strong vertical route. If you're such, you're going to specialize, and that's what you're going to spend a good chunk of your time specializing in and doing. Gastronomy, neurology, pediatrics, whatever. It's very specialized in those areas once you leave the primary care route. How did you guys work? How's an NP versus a PA work with a physician? Are they very similar? Are they different? Is there any similarities? Are there vast differences in how you guys interact with physicians? So, Jillian, we'll start with you again.
So in the role I was in at Kaiser, which I was really part of their team, I was just part of their team. I mean, and it's not like I had the lower level patients or anything. I mean, I could have the sickest of the sick. It's sort of like, okay, you have room on your caseload, you take the next admission. And I always worked with them, but Kaiser's whatever it's like their credentialing or whatever that I sign my own orders. I don't have to really have cosigns because that's all taken care of in the background. I mean, you do work under the supervision of a physician, but you have tremendous autonomy. So it was a very satisfying role that way. And I mean, I was a valued member of the team. The only and not to slam unions, but the only gripe I had is that the nurse practitioner role at Kaiser is in the union. So it limited it when if they had a hole in nighttime schedule and they wanted me to cover night shift, I mean, I'd be happy to do it, but it was so expensive. I made more than the doctors because of the union. The overtime after 8 hours is time and a half, the double time, and it was just ridiculous. It's kind of obscene. And that's unfortunate because I think that it has limited the growth of those inpatient practitioner roles in doing that. Because the original practitioner roles at Kaiser were outpatient, like employee health and things like that. So in the inpatient setting, you need more flexibility. But I'd say just another member, a colleague of the team with my position over there.
Sarah?
I just wanted to touch on something you mentioned, the breadth of the amount of career change you can sort of do as an NP, and I think as a PA as well. Physicians tend to be, I mean, you're kind of Nurses, I mean, I could change every year. I could work in a different area if I wanted to, honestly. Um, and I think that's great for me. You have to know what you like, and you like to be able to mix it up every 6 years. You feel really confident in what you're doing. Now I want to try, GI. Now I want to try neurology. And you can do that. As a family nurse practitioner especially, you can go in all kinds of directions. There are different types of nurse practitioners. You can get your degree in pediatrics, you're a pediatric nurse practitioner, and then you're kind of going to work in that arena. But family practice or something more general, you can jump around for a while. And then the relationship with the physicians, my NP job was in occupational health. I was the only medical provider on site for 3,000 employees. There was no physician anywhere nearby. According to California law, kind of dictates your practice. So the nursing changes depending on what state you're in. Actually, the laws change quite drastically. So California, we're kind of in the middle with what we allow nurse practitioners to do, but it's moving toward full independent practice for everyone. So now 22 states allow complete independent practice nurse practitioner. You can open up your own shop. There doesn't have to be a physician involved at all. So California is sort of in the middle ground where a physician has to be available by phone. A physician has to own 51% of a practice. Just kind of like goofy little laws that are slowly being taken away and changed over time, and it will go to independent practice. But I pretty much practiced independently, responded to emergencies on my own.
I'm glad you brought that up, the independent practice, because that's a big difference between nursing, nurse practitioners, and PAs. So physician assistant was designed to always have supervision of a physician. So it's definitely a network team program. But supervision can be on many levels. It can be a phone call away. It can be right in the office next door. To explain my role specifically, which is one just subsection of what you can do as a PA, I work alongside in the clinic, which means you see patients with injuries, come in, evaluate them, and decide what to do. And then in surgery, so because I'm not trained as a surgeon, I can't do surgery on my own, but I'm the surgical first assist. So in that arena, the surgeon, the doctor, and I are working side by side to take care of the patient as a whole. On the clinic side, I have a little more autonomy, like they were mentioning. I have patients of my own on my own schedule, and they never see the physician unless I feel like they need to be escalated to a higher or more complex level of care. For surgery in particular, there are surgical problems and non-surgical problems. And so for a PA, we can take care of and manage the non-surgical problems, which can include casting, injections, diagnosing, and treating. But if there's something that's just not going to get better with surgery, that's beyond my level of care, and that's where it gets escalated to my next team member, which is a surgeon. And maybe I'll talk about this a little bit later, but that's a good model for efficiency in healthcare. It's cost effective for doctor's level salary versus my level of salary. Not that it's poor, but to take care of the majority of problems and save the more complex cases for the surgeon is a very efficient healthcare model.
I think that's a really important point, if we could stay on that for a second, because what we've seen with the advent of the Affordable Care Act and Obamacare and the spread of the ability for people to have healthcare insurance is, just speaking from a Kaiser lens, we've seen enormous membership growth related to that. So, I think I was at a lecture recently where they said 95% of Americans have health insurance now, which was certainly not the case before that legislation passed. And the impacts on some of on these healthcare systems is that we've had rapid membership growth. So we honestly are struggling in some ways with access to healthcare because our old models don't work, and it's really forcing. Kaiser's always been out ahead in this, allowing people to practice to the top of their license, but there are other models where the doctors did everything because they got paid to do everything, so that was part of their way of making money, and that's all shifting to be paid for performance. There's really much more emphasis on keeping people well, and reimbursement will be tied tied to wellness, you'll only get so much for illness, and fits well with Kaiser because we've always functioned that way. We've been a prepaid model. We make more money if you stay well. I mean, if we have to do a lot of care on you, then that feeds into profit, right? So, so I just think it's interesting that we're going to see that more. There is going to be a growth of these roles and much more demand for this mid-level practitioner to meet that demand of access.
Currently, right now, at this stage, how many percent, what's the percentage of the patients do you actually have to defer to the physician versus the percentage you guys can take care of your own? Let's start with you, Jennifer.
1%, 1 to 5%.
So between 95 to 99% you
Probably
take care of.
once a week, I'll ask the surgeon to review something for help. And as I'm only 6 years into practice, which seems like 6 years, I've been doing that for a long time. But I think that's pretty young in a medical career that's just getting out of residency. If I was going into med school when I started PA school, so I wouldn't even be done training. But certainly in the beginning, when you have this much knowledge and experience, you'll be asking for help a lot more to verify. And now I have more of an inkling and experience, so my level of autonomy I'm more confident in, meaning I don't have to ask for help as much because I have more experience and more confident in what's the right and appropriate thing to do. So I can't say 1 to 5% early in my career, but definitely now 1 to 5% of the time. So most of the time I'm on my own.
Is your job a Monday through Friday job?
Yes.
What are your hours?
I'm 8:30 to 5:30. I have a regular schedule during the day with lunch break. Operating room days are daytime hours as well. The only thing is when you work in a surgical practice, there's no quiet for the hospital, right? Someone has to cover 24/7, even right now. So I'm taking call, which means I have a pager, and if something surgical comes in, one of you drops down there with abdominal pain, needs your appendix out, I get called in. No matter what I'm doing, I have to drop and go help the surgeon. So there's always a team of on-call. So that's the only difference between outpatient physician assistant. So if they're running primary care, they're probably 8 to 5 Monday through Friday. But I take a little extra hours because I'm on a surgical service.
Sarah? Percentage you would refer to?
Pretty small, because the physician that owned my company was based in Southern California. He couldn't get there for things. So it was kind of, here and there I might bring my cell phone with me out into the field when I'm responding to an emergency, just for confirmation, because I was a new nurse practitioner by myself with a lot of people out there. But yeah, mostly it was because the company wanted his check mark on something. And as a nurse practitioner, you can do whatever you've been trained to do. So if I hadn't done a joint injection before, he would fly up and he would sit there with me and basically talk about it before we did it, and then I'd go ahead and do it, and it was done, and now I'm competent at it, right? So then I could do it.
See one, do one.
Right, that's kind of how it works, because in our training, I think in medical school you probably get a lot more, it's much longer, and in your residency you've gotten a lot of exposure to all that. And in nurse practitioner school, it kind of depended on what clinical rotations you got, like, you got the one you wanted, or you got an ortho one, or you didn't. So I never got to do suturing in my, in school, but of course in working in sort of a dangerous occupational health arena, the first time someone comes in and needs sutures, that's me. Somebody, flies up and shows, here we've done it, now you're competent, now you do the next one, kind of thing.
Awesome. How percentage, when you were practicing, percentage?
So I think that the job I had at Kaiser, the physicians were always there, so it was always a team approach. But as I mentioned, later in my career, when I actually started working more in technology, I would continue to moonlight. I moonlighted at Doctors Medical Center in Modesto. So I would drive down there, and they would do 24-hour shifts. So I'd be there in the daytime rounding with the physicians, but at about 4 o'clock, the physicians all went home. And it was a 54-bed unit, and you were it. So if there was a premature delivery, or something comes to the ED that's related, where the baby's born early, that you get pulled into any of that. You just stay in house, you sleep in house, handle any of the stuff that happens with And probably the most, I'll just share the most harrowing experience, because I know this doctor did not want to come in, but I had 24-week triplets, and 24 weeks is really,
Wow.
these are really premature babies, and so 24-week, they all need airways, they all need lines, they all need everything, and he came in for like 30 minutes, and he intubated one, I intubated two, we put lines in them all, and then he left and I had to do all the paperwork and transfer them to Stanford. And so it's that type of thing. It's like you have to have a little, they'll come in for that type of help, but essentially you can kind of handle it all. I mean, you learn and you do. I mean, it's just a matter of there's three at once. That's why you couldn't do it. So
It's pretty crazy.
I
Okay.
think in the mid-level role in general, the point of this lecture too, that we can take care of a lot of the groundwork, and it's a great career choice in medicine if you're not sure you want to specialize or take the road of being a physician, because it's quite a different road
yeah,
to get there.
yeah.
And then the outcome and what you end up with and what you end up doing is also very different.
Yeah. It sounds like if the goal of a person is patient care and contact, it seems like a quicker and definitely a lot cheaper from personal experience path to get there. And you always have someone to basically, if needed, back up it very soon. You won't need that by law anymore.
Yeah, that'll be interesting. I mean, like I still have my furnishing and dispensing number. I mean, I could write prescriptions still. I mean, sometimes that's a little dicey because you're really supposed to work for the doctors. I mean, the most prescriptions I've written is for my cat, but it's like I've never let that step go. I've never let my license go either, even though I'm not doing clinical practice, because I just feel like it's sort of part of who I am.
I'd say a lot of the restrictions are just kind of a piece of paper, because in healthcare we all collaborate no matter what.
Yeah.
And to me it's so goofy that somewhere, we're self-regulated, we have a board of nursing, we have licenses. Somewhere some lawmaker thought it was a good idea to write that you have to talk to a colleague if you're not sure what you're doing. And it's my license and my training and my ethics tell me that. Why is that a law? What's to stop a dentist from performing a knee surgery, right?
Yeah.
It's really kind of silly, and it's become a little bit of a turf war, and it's cost healthcare a lot, I think.
Yeah, it's political.
It's so political. And so we're kind of in a battle right now. There's a big bill that's in the session this year to sort of give independent practice to nurse practitioners, but it's silly things that you couldn't do before, like you can, all kinds of stuff you can do, and you can prescribe narcotics and whatever, but you can't sign a disability placard for someone to get for a handicapped parking spot, right? You can treat patients all by yourself. They could never have seen a physician, but you can't sign the form that says they wouldn't want CPR if they were to go into cardiac arrest. Why do you have to wait for a physician to come in to sign that form who doesn't know the patient? It's just
Or their
goofy.
family.
They know nothing about it. Anyway, that law was changed last year. So we're slowly taking these little tiny pieces, which is really goofy. But it's just a political battle in terms of turf war, kind of. It's silly, but I've learned, I never thought I wanted to get into politics much, but you kind of have to when you're in healthcare a little bit, because it affects so much of what you do. And it's just the lawmakers don't see it and don't understand. But when you put it in terms like that, when you say, I can't order oxygen for my COPD patient at home that I've been treating, for 10 years, I have to find a physician who will sign that. And meanwhile, the patient's going without what they need.
Oh, I forgot the question.
Yeah, I
Oh.
know.
So I can tail on
Yeah.
that, is that I think a lot of this is happening because of the demand for mid-level practitioners now. It's very much more common, it's out there, it's more well known, and the demand is definitely to meet patient needs. There's more people needing healthcare, there's more people that have access to healthcare, but there's not enough appointments in a day to take care of everybody. So they need people, so there's not enough physicians to take care of it. So they need people mid-levels like us. The legal has always fallen years behind what's actually happening. I think why do you need someone why is there value to a piece of paper and a license for one person more than another to do something very simple? Like have the hammer hit the nail. It doesn't matter who's doing it, but it actually does legally, and it unfortunately carried a lot of weight in the past, and you're slowly transitioning, which is why there's so much politics going on for mid-level practitioners. Something that you may or may not be interested in the future, but I think the point too is that there's clinician roles and not clinician roles in healthcare. You don't have to be treating a patient, touching them if you want to be involved in healthcare. There's other roles involved.
Yeah, so we're really in the part of the work I do at Kaiser Permanente now is really looking at what's coming in the future. So in that innovation space, and we're really looking at different care models to meet these access demands. And the new emerging role for physicians is what we're calling a virtualist. And they sit here in this room and they care for hundreds out there through technology. So it may be remote monitoring, it may be a video visit, it may be a phone call, but they're in their jammies, doing their job. And so I really see we're gonna have an emergence of that where we are going to care for higher and higher acuities in place in their homes or where they live. So, and how, what are the models we have to set up in the technology to support that?
My last company did a lot of telemedicine, and I think that's definitely, you're probably going to ask this question, this is where healthcare is going, but a lot of telemedicine coming from all across the country, which brings up interesting issues with like licensing is per state, so you have to have a license in this many states to practice.
That's a perfect segue. So, would you say that, from what I'm hearing here, the roles of NPs and PAs are constantly expanding to more and more responsibilities and autonomy, right? So, let's say 10 years from now, 2025, based on what you've seen so far, where do you think nurse practitioning and physician assistants will be in their autonomy and responsibility, and how would that actually impact on how those physicians coming out, basically these guys here, because that's going to be 10 years exactly when they go through medical school and residency, what's this going to look like for positioning and turf and responsibility dynamics?
So I think the autonomy of the mid-level practitioner is going to continue because it needs to, because of just mere access. There is enough work for everybody. If you are a trained surgeon and specialized and you've gone through 27 years of schooling, there's still a need for your services for sure. The turf war is going to change we're disrupting healthcare with the change in healthcare because as you remove the profit motivation from providing care, which has really been the traditional healthcare model, is like, as a physician, I make money caring for you. I bill for everything. And there was not really a lot of questions asked, and that has, there's lots of stuff out there about the abuse of that and people making gobs of money. That's really changing, and I think, medical education and the cost of medical education is going to have to change with that to keep a traditionally changed doctor, because you cannot come out with the debt that you have. You are not going to make the same amount of money that a doctor made 20 years ago. You are not going to, because the models are changing. And we are bringing down the cost of healthcare, and part of that is that, all the fat cats that were in healthcare. So I think these roles are definitely going to grow, but the bickering over it's going to change, because that bickering was because we were eating into their profits, and that's just not going to exist so much anymore. It's still there today, but we're going to move in this direction, because that's definitely where all the tide is going. So that's my opinion.
Sarah?
You can go last. There's going to be the role of nurse practitioners and physician assistants definitely expanding. I think it's going to be we're going to be in every little corner store around. Every little place is popping up a little stand of healthcare, and it's as quick as you can get it right here while you get your groceries and all that fun stuff. And it's going to be focused on customer satisfaction and efficiency, which it already is, which has its own issues in healthcare, really. I don't know if this is the right time to delve into that, or that question comes later. But, so reimbursement for services is a lot based on patient satisfaction surveys. Things are changing. I'm working in a hospital environment right now, and Medicare and Medicaid will only 30% of their reimbursement is based on patient satisfaction. So can you see any problems with that? Research shows that, go ahead.
Oh, with patient satisfaction?
Yeah,
Well,
for patient, based on patient satisfaction.
Well, obviously, patient satisfaction is very subjective.
Yeah.
So, like, perhaps it would put facilities in competition where it gets to the point where you need to, like, roll out a red carpet for the patient or something.
They're already doing that.
Oh. Oh, wow.
What?
Faster than I thought.
Any other comments about what you think patient satisfaction-based compensation problems would be? Is it perfect for you guys? Yep.
I actually had a question from earlier. So you were saying that, like now PAs and nurses are taking a more prominent role in administering healthcare. But I was just wondering, like, is there any stigma around that from patients who are traditionally like used to seeing a doctor or something? Explain on that, yeah.
I would say yes in my experience. Definitely that's one of the challenges that I knew going into it, and I'm probably going to face the rest of my career is, hey, what do? You're not a doctor, why can't you do this? And I said, it's just really sitting down explaining, like anything else, education. It's one of the things that I found annoying at first, and now I just take it as part of the career and find it satisfying that if you set the stage for mid-level providers and educate now, then they go down the road to you, and they know what to expect, and you set your colleagues up for success, and really there's no way around it, because this is the way healthcare is going. It's a funnel, it's not going to change and go back to, I need to see the doctor only, it's going down that road, so as long as you can keep them up to date on how things are going and setting the expectation, then it's really not going to be a big deal for patients in the future, I don't think.
I think more and more people are knowledgeable as it's in the media, it's in the news. When they go, they've seen, nurse practitioners before, and a lot of people tell me that they prefer it, or once you spend the time and you're able to kind of come from maybe a different approach, or you're able to spend a little more time with them, they really appreciate you, and I know a fair amount of people who only want to see PAs and NPs.
Yeah, I just like that comment, you're setting up your colleagues for success, so if you provide a satisfying experience for them, and, then they're not afraid of the next time they see a diploma.
We are confusing the public with so many different ways to go into a similar role. But
Yeah.
I compare myself to NPs all the time, because it's much more a household term. I think nurse and then more nurse practitioner pay is still lagging behind a little bit, so they're like, what do you do? What's a PA? And seriously, the first thing I say is, well, do you know what a nurse practitioner is? They're like, yeah. I'm like, okay, very similar. We act on the same level. We can take care of you if, you're worried or I'm worried. There's always a backup, team member who's a licensed physician to help me out. But that's really, I compare all the time. And from a personal standpoint, I find no competition.
Yeah, I think the biggest difference is really the educational model, and you sort of
It's just how
address
you
that,
get trained.
versus a nursing model versus a medical model, and that's probably the biggest difference. And then I always think of PAs in surgery. It's a much more prominent role attached to surgery.
So we're talking about how MPs is this gonna happen, that they're gonna get their own licensing, open their own offices. Is that gonna also happen with PAs, you think? Where they can actually be almost autonomous as well, because their training is very similar in their skill set?
I don't know. That's all on paper, because the reason why PAs came about was military had people working as medics, and then they came back to the United States and home and had no job because they had all this medical training, but to go through med school, really 10 years more, even though they had the training already, it was a fast track to get a license to practice and use your skills that you had out there. So that was the original formulation for this career in the first place, and it was always under the supervision. And so I think that tie for PA, I have a hard time seeing that that's going to ever break soon. Maybe, but my personal experience now is I'm getting trained as a resident. I'm doing more and more, because it's all like you guys, you'll hear this coin term, practice at the top of your license. Well, there's really no cap for mid-levels. It's whatever your supervising physician allows you to do for PAs. So that could mean I can do my own surgery with proper supervision, and honestly, that's what we're training to do right now, is doing more and more.
Do you have to go through procedure credentialing? You know, get signed off on procedure, you know, kind of the stuff they do? Okay.
Yeah.
Okay.
There's this goofy thing in the law for nurses, I don't know, for NPs, I don't know about PAs, called standardized procedures. And I didn't find out about this till last semester of NP school. I don't know why it didn't come up before, but anywhere you practice has to have a book with every procedure, every
That's
patient
And
encounter,
you'd be credentialed on those.
every type of patient that comes in. A patient that comes in with a headache, this is what you're allowed to do.
Yeah.
This, prescribe this, and this. And then it has to be reviewed and signed off between the two parties. Has anywhere I've ever been, have I even seen this book?
Do they sell them?
I've never seen this in existence. It has to be there by law, and people, you know, nobody practices based on these silly things. Like, if I didn't have an advanced education, maybe I'd flip through and see what, you know, et cetera.
Now, see, when I got hired at Kaiser in that nurse practitioner role in the NICU, I had to write those.
Yeah.
So I wrote my own, and then they signed off on them. I mean, and there's a lot out there, so it wasn't like I made them up, but I mean, you know, I just had to create the structure for meeting that rule. And then any procedure you do that's actually a medical procedure, like placing a line or, you know, there's many things, intubation, I had to be signed off on it. So somebody would watch you at least do one, your comment, and then you're signed off and you're okay, good, you're gone, you can do it, you're on your own now.
So, interesting, we have two Kaiser representatives here today. So, in the next 10 years, obviously, we've talked about this, another player coming in, Walmart coming in as a new player and providing care, bringing clinics into their scope. When you have three main players potentially coming in, Target and Kaiser, looking at what they can probably do together, but at least you'll have at least two big players coming in. How does that, when you have these huge employers coming in like this, and can hire massive amounts of providers, how does that affect the job market for PAs, NPs, and physicians? Like, how does that scope in 10 years look as far as options, restrictions in the job market coming out of medical degrees? Let's start with you, Jennifer, this time, or?
Well, I think competition, opening up the field is excellent for job opportunity. You are trying to meet the demands of the patients out there, and how are you going to do it cost effectively? I think maybe one thing we didn't really talk about as far as considering a healthcare degree or entering into healthcare is that bottom line, this is also business. This is no free lunch for anybody. You're providing a service just like anywhere else. So part of the future is taking into account how are you going to have a sustainable career and get paid and provide services to everyone at the same time. That's why there's so much talk about the cost of healthcare. Why do we even care about the cost of healthcare? Is because it actually matters to you as an employee and to the patient receiving the services, because you got to shell out the dough for what you got. And if you're going to pay $500 for a flu shot, I don't know if you're going to do that. So there's a nice balance moving forward on how we're going to meet the expectations of the patients and the business, and then also the employees at the same time. But just to answer your question about Walmart and competitors, I think for career-wise, mid-level providers, that just opens up the job market.
Yeah, I mean, I think it's going to open up the job market substantially. Now, we do have a model at Target in our Southern Cal region, where it's nurse practitioner run Kaiser little pod clinics in the Target stores, and we have a physician available by video. So if it's something beyond what the practice is for the nurse practitioner in that spot, then they just, put them in, get them hooked up to the physician on the video screen. I would go nuts in that role, but there's many people that's exactly what they want to do. It's great, it's very it's like, fevers and coughs and earaches, and it's pretty straightforward primary care type conditions. So I think that's only going to grow. We're seeing that pop up everywhere for those, for practitioners and even RNs in some cases. So I think it'll be good, from the market standpoint. And then I think there's opportunity for physicians. If you're not going to go in a traditional physician role, there's so many business opportunities for physicians, because all of these programs need medical directors. They need people to run the operations, and you know, there's a tremendous amount of opportunity for physicians too. When I think of, I get in the innovation world, I get a lot of exposure to up and coming companies that are venture funded. Boy, that whole space of medical venture funding is really fascinating. And here in California, we're so close to the hotbed of it. You know, and how people are making decisions about where to put money and what's the next big bet in healthcare, and it's just a trip, you know, and some of it's going to pan out, some of it's going to totally flame. So, yeah.
I don't know if I have any more to add. Lots of opportunities, yeah, opening up for sure. You can work in any arena that you want.
Very cool. And I'm looking at our time here. How long?
Oh no, we don't have to.
You
This
sure?
is fine. No, I'm fine. This is good. The discussion's good.
Okay,
So.
okay. I didn't want you to like.
No. This is just. I just pulled this out.
Okay.
Kaiser stuff just in case.
All right, cool. So, in your great example here, Julie, what are obviously you come out with this degree and you don't have to be locked into clinical practice. Obviously, what are some options that you've seen and you think in the next 10 years, because the next 10 years is going to be just an amazing different diversity and different branchings and a lot of divergence coming out. What are things that you potentially can see with an MD&K degree that there are things that don't exist now that you think that are directions that are going right now that you can do with an MD&K degree that are not clinical based, but like
yeah, and obviously the huge opportunity right now is in technology, and I mean, I know I don't have to tell any of you that healthcare was like the last big sector to become like, you know, into the you know, the age of today, not the dark ages. I mean, really, truly, we were just talking earlier about there are still lots of places that are still on paper. And you can't imagine that you would do your banking on paper anymore. I mean, even when you fill out a deposit slip, it's like, what? You know? And in healthcare, I mean, it was 10 years ago, about 10 or 11 years ago, that Kaiser started their medical record implementation. So that was really moving off of paper. And that's just not that long ago. I mean, it's weird now to think about it because we're so into where we've moved the trajectory, but we were kind of one of the front runners in this area to delve into it. So I think technology is huge. I mean, any background here. The other thing that is really fascinating, this is recent exposure to me, is this whole area of human-centered design and, you know, working with consumer engagement, because that's also the big change in healthcare is that traditionally healthcare is you came to us and you went on our schedule and you waited on the phone till I could talk to you, and I don't really care if you're, you know, missing picking up your kid from school. That whole thing has to change because there's competition, and now it's all about, oh my gosh, how can we serve you the best way we can? And that's a big pivot. So change management, working with people to understand how, you know, traditionalists, you know, older people in medicine, how do you get them to change, make that pivot change? But also all the tools and all the ways that you create things that we use in healthcare so you understand that empathy piece, how it impacts somebody. So like, you know, all the great feelings you get when you use your iPhone and all this stuff that's so friggin' easy to do on that thing. And we just aren't there in healthcare yet, but that's a big discussion point right now is how do we get there and what do we need to do it? And I think the traditionally and classically trained designers and people with that talent are really, really important in this space right now.
Oh, geez. Trying to think of other arenas that you go. There's also, you know, education route. There's also international kind of healthcare, public health kind of routes to go to. But yeah, with all these sort of changes, I think the Bay Area is probably, you know, hot on all those kinds of changes. But then there comes other issues like how do you bill for those types of things? And I don't think health insurances were set up really for those, you know, the texting your doctor or the emailing. Like, how do you bill for an email? There was never a billing code for like time spent emailing your patient, right? So all these other systems have to change to sort of keep up.
It's a good point because really the legislation and our government is far behind what is really happening. So you can't get paid, like in an urban area like this, we cannot get paid by Medicare for a video visit. It only is paid in a rural environment, you know, which is traditionally how those were used, is it the distance, discussion. And that's ridiculous, because we're doing a large amount of our business now this way, so.
And other challenges being, patient satisfaction is a good thing, customer service is a good thing, but where does that become a hindrance or a bad thing in healthcare? We have a problem with narcotic abuse, right? Your patient that just wants an opiate, a narcotic for their pain, is that the best thing for them here? Are they gonna leave more satisfied if you just give that to them, or if you don't? And how is that gonna impact
Question.
your reimbursement? The patient who wants a full body MRI scan has no indication. The patient who comes in with a cough, a clearly viral thing and wants antibiotics for contributing to antibiotic resistance. So those are some issues where, so that consumerism part is not necessarily the best way to go, but there's a middle ground somewhere in there. And I was gonna say one more thing, and that escaped me, so.
Good, Jennifer,
I'm
open
not
up.
sure if I have anything more to add as far as the role of a PA once you're a PA and you don't want to be a PA anymore, because it really is limited currently. So you don't have the potential for independent practice to pairing with a supervising physician. I think the majority of PA jobs are clinical, meaning you work face to face with patients. There's more PAs going in administration. There's always management positions wherever you go, process improvement positions, and because all these X factors are coming into healthcare, including customer satisfaction, there's a lot more positions to analyze how we can improve that arena and how we're able to negotiate with patients and what's going to be better for them. So you throw in X factors, and then there's always a job to analyze and improve that X factors. So I think any clinical experience as a PA will be valuable into process improvement jobs in general, but right now in my experience, I don't see that many PAs in management. A lot of them are in clinical.
How old is the PA profession?
70. So what does that make? Maybe 40 years?
40 years?
Yeah.
Wow.
Mhm.
Okay.
Some people coming home from the war.
Okay, makes sense.
I thought of the one other thing.
Yes.
I was gonna say, the other challenge too, like the virtual medicine and the texting, emailing your doctor thing. And I've seen a few people in my occupational health who had seen their provider, which meant through email to them. They said they were fine, and then they came to me to come back to work or whatever. And it was clear that they had an issue only because I was able to listen to their lungs.
Oh.
She has a pneumonia, right? You would never know that, over an email. Right? You can't listen to somebody's lungs. So the traditional aspect of how do you know if somebody has, appendicitis necessarily, you can't press on, So the physical aspect is there. You can certainly be led towards a certain path, but to the hands-on aspect is important too.
I got a few questions, but I want to open it up a little bit, make sure we have time. You guys have any questions so far? While we've discussed about how these roles will be affecting healthcare impact and providing healthcare business changes in the next 10 years. Any questions at all? Yeah.
What has been your biggest challenge so far in the roles you guys have taken on?
Wow.
As a PA, I think the biggest challenge, and still consider myself young in my career, is getting enough experience. So you train, but by no means do you have all the experience you need to practice completely competently, meaning completely safely. You know what you're doing, you know that's the best thing for the patient. So with 1 year of clinical experience under my belt and 1 year studying in the books to come out and then to have some very complex case, it's just, I'm not going to meet that expectation. So I think my biggest challenge was really investing in the first couple of years and treating it like a medical residency. This is for learning. You're going to ask a million questions. You're going to have to feel comfortable being uncomfortable because you're not going to know everything. You're also defining your comfort level of where do you stop with what you don't know and then ask for help. Some people's minds are very far and some people's minds very conservative. I'm pretty sure, but I'm going to ask anyway. That's mine. Some people are I read it and I saw it on YouTube, I'm gonna try it. And once you have a license, you are legally allowed to do that with supervision. So really it's taking it upon yourself as a person with the ethics that you mentioned earlier. And I think mid-level providers go into mid-level provider positions because they're set up for success there. It's, I'd have to say in my experience, more personable, person-oriented, compassion to take care of the person versus just basically science-oriented. I love the medicine, I love how the cells work. That's not personally why I went into medicine, to take care of somebody. And that's really what drives that continuum scale. Of course, now with experience, I feel like I can draw back a little bit and say, I think you're gonna be fine, and confidently say it. But that same case come in 5 years earlier and say, I gotta ask somebody. So I think that was my biggest challenge, is growing into my shoes, I should say.
I think my biggest challenge is kind of spiraling off of what you said. You go into a healthcare profession because you want to help people, right? Mostly. Uh, my biggest challenge has been nobody prepared me for what the system is like, and I come in with my cape and, you know, here I come to change the face of everything, and the system beats you down, right? See, they get it, right? You can't do all the things that you wanted to do, and to try not to let it get me down, I have to take breaks away. I've gone and traveled, kind of refreshed myself, and come back ready to fight the system, because there's so many challenges, so many challenges. Most of what I ended up spending my day doing was nothing like what I thought it was going to be. It was very little patient care, and when it wasn't the patients I thought I was going to have, and I found myself walking, my medical assistant would say, there's somebody here to see you, and I'd go, oh, God, because it's somebody who wants something that I don't think is right for them, and I try to explain it, but they don't get it. They think, Wikipedia is their doctor, and it's hard. It's really hard. So you have to keep motivating yourself and surrounding yourself with people that build you up, and keep fighting the system. It's going to change.
And I'm just sure I had a challenge when I took that first nurse practitioner role at Kaiser. And it was interesting. It was like a challenge with my own people, with the nurses, because I was hired by the Department of Pediatrics and reported up through medicine. I had a lot of like, who do you think you are kind of stuff, and which was really fascinating to me. And so I really had to, well, I was also in a learning mode, like you alluded to. I had to work with the nurses too, so I was very cognizant, like when I was on rounds, that I made sure I involved them in the rounds, like, how is this, tell us about how this baby's been eating, and blah, 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 blah. And leveraged their expertise, because the nurse really, nurses in an intensive care unit, man, they're right there at that bedside, they know everything, and they're really your ally when you're in a medical role. And so I just worked hard to make sure that connection happened. And I also, I'd come from 9 years at Oakland Children's as a nurse, and I had gone to school while I was at Oakland Children's, and that is a very high-level tertiary center, so I'd learned a lot there, and I worked with a lot of really great leaders, and I had a lot of knowledge, but I also didn't really want to say, well, wow, you guys should do it this way. So I shut my mouth for 6 months unless it was something totally unsafe. And I would just take notes in rounds. I still have those notes. I had like 2 pages of things that I thought we should address as a nursing team that we could improve upon. And in 6 months, I was part of the team. They liked me. I made my way in there. And then I started to execute on my list. And so it was a good approach. But that has nothing to do with being a nurse practitioner. That's like change management. It's just like common sense, working with people, engaging in forming relationships. And I'll just say those early experiences of having to do that have served me my entire career, because really all of these professions are about working with people, which is
People skills. Learn them. You're gonna need them.
So I guess my question is, have you seen any technologies that have like significantly changed like your day-to-day in the front line, or do you think for patients who like have a lot of health apps, like does it really help their condition or does it help you as a practitioner?
Good question.
I graduated in 2013, so I feel like, how did any provider or practitioner ever make it without their Hippocrates, their up-to-date, their medical apps that tell them this second, this is
We
what
have
all
all
the
these
research
books
shows.
in our lab.
I don't know, all these, this whole textbook thing that have my apps, they're updated, they tell me this moment what the evidence-based practice is, and I don't know how anyone ever made it without that. And I think to a certain degree, it's helpful to have a patient think they know what's going on, but then it's also terrible in some degrees, because they could sway me sometimes.
Yeah.
They can sway me, and it's it's not necessarily the right way to go, and they come in demanding often what they think it is they need, and then you spend most of your time explaining why
they
that
don't
is
need
not
it.
necessarily the case, and this is also, something that they need to consider.
Just sitting from a tech side of things, I think that's $1 million question. I think we're really struggling with it at Kaiser Permanente. Like, really, what are the models we should be putting in place? The studies on just say we're going to monitor remotely a certain patient population, like people with congestive heart failure or something. And those kind of patients, elderly, frail, if they eat too much salt and they start to get short of breath or they gain weight, we can kind of predict you might have an ED visit coming up. I mean, there's just, when you manage those patients, you just know those things. Can we apply remote monitoring on a broader scale and be looking for those things that are indicators that you're going to get into trouble? Because it would be great if we could intervene early, and maybe it's just a phone call to go over what you're eating. Maybe we need to change your medication. We can do it all remotely, or maybe we need to send a visiting nurse, a home health nurse out to see you. We have not really applied those models broad scale yet. We are dabbling all over the place in that right now at Kaiser to understand what makes the most sense. And the whole fitness thing with the sensors, and no clue how to use that information yet. Because when you really think about it, it's just tons of information and data, and what do we do with it all? And so you have to, where are we going to put it? What kind of analytics are we going to do on it? What are the actionable insights that actually really mean something we should do something about? So that's a big morass space right now that we're trying to grapple with.
I think, for me personally, electronic medical record is excellent. It was a great transition from my prior practice that has helped me a lot, just clinically practicing as a physician assistant every day. It's made navigating a patient in particular very easy. And I felt like I could give better care because I'm aware of their entire medical record, not just a small portion of it, or what they tell me, or this little piece of scrap paper they scribbled on with the wrong words. So I think that's communication through electronic medical record has been very helpful in aiding me to give them good care. Even just simply electronic messaging back and forth. Hey, I'm worried about this. Is this normal? Yes, it's normal. No, I'm not worried. Tell me more. That's just made it a lot easier for myself and for patients, and I think patient satisfaction too. But also on the data collecting side, when you have one integrated medical record, and fortunately I work for a company that has it all integrated, you can collect data and pieces from the medical record and use it as a survey or predictor, and that's beyond my scope, but I think that it definitely will change preventative medicine for sure.
So I just have to share a story, because when I'm like old enough and worked for Kaiser long enough that I was there before we went live on the medical record, and I actually that was the work I was doing as a consultant, was working with our Northern Cal region before we went live on the inpatient part of our electronic medical record. But I remember as a nurse practitioner at the Oakland Medical Center, the old Oakland Medical Center, the OB offices were across the street on a little street by the parking garage, and there was a tunnel that went under the road to the main hospital that so you didn't have to cross above. Every night at the end of the day in labor and delivery, some poor guy would wheel over this huge file cabinet. He would bring it down the elevator, through that tunnel, and up and park it in labor and delivery. And they were all the prenatal records for all the patients who were 34 weeks and greater who had not delivered yet.
What year was this?
This was 1999.
Not that long ago.
No, it's not that long ago. And that was done because if any of those women came in and in labor and delivered their baby early that night, there was no one in the office to give any of the prenatal information. So I use that story because I was involved in organizational readiness when I first got back hired with Kaiser in the IT side. And I would use that story because we were doing this forest and trees thing. Like, how do you get people to embrace the electronic medical record who were like so paranoid that it was coming? And I'm like, look, here's an example of efficiency that will be delivered from this, you know. And I swear to God, we did that every single. And then he'd show up at 7 in the morning and he'd wheel them back. And so the point being that record now, if someone comes in, we have full access to their prenatal record, to their, you know, pediatric record if they've been a member for a long time. So, you know, you can see everything.
So 1999. You guys were alive back in 99, right?
I think it was even 94.
That could have been your record.
I mean, honestly, I was working at 93, 94.
So my last job I left in 2015 was basically is still doing that.
Yeah.
Oh God, still?
Yeah.
I'm writing notes on paper, like the charts, they're this thick, they have 3 charts, they're falling apart, I'm trying to carry them, I'm gonna get an occupational injury.
Yeah.
I have to treat myself. They still send all the files to storage every few months.
Yeah.
It spends, like, my medical assistants would spend like a week going through all the charts, putting them, it's just so much wasted time.
Yeah.
So I think we're done. Do you got any last questions? If you mob these people, please. I'd say, you know, definitely if you want to find more about healthcare innovation and technology, Julie's the person you want to definitely talk with. Anything to do with PAs and NPs, they're recent grads because they just got out and they actually can tell you